Acha, Assalamu alaikum everybody. If you can hear me, please reply in the chat box. ठीक है. चलिए, let's just wait till अभी 3:1 है मेरे पास. So let's just wait for till 3:05 and उसके बाद I'll start inshallah. ठीक है. अच्छा, I am going to unmute everybody because like I said yesterday ये एक interactive session होगा. तो मैं आपको अनम्यूट कर रहा हूँ, लेकिन आपने अपने आप को म्यूट करना है. एंड इस तरह होंगी कि बीच में स्लाइड्स होंगी, तो आई विल पिक पीपल एट रैंडम फ्रॉम द लिस्ट ऑफ द पार्टिसिपेंट्स, और उनमें से मैं एक बंदे को कह दूंगा कि भाई जी आप बताएं कि आपको इसमें इस एक्सरे में क्या नजर आ रहा है. ठीक है. सो आई एम अनम्यूटिंग ऑल ऑफ यू एंड आप लोगों को मैं ऑप्शन दे रहा हूं कि आप अपने आप को खुद अनम्यूट कर सकते हो. ठीक है. तो आई जस्ट गो टू द पार्टिसिपेंट्स लिस्ट एंड उससे आप देख लें. जी डॉक्टर नहाल, आपको मेरी आवाज नहीं आ रही? ना ओके, चलें ठीक है. अच्छा, आई हैव गिवन यू ऑल द ऑप्शन टू अनम्यूट योरसेल्फ. सो बीच में जब मैं स्लाइड लाऊंगा किसी एक्सरे की, तो उस वक्त फिर आप लोगों ने अपने आप को अनम्यूट करना है एंड यू हैव टू टेल मी व्हाट यू थिंक इज ऑन द एक्सरे. ठीक है. सो लेट्स जस्ट वेट फॉर अ कपल ऑफ मिनट्स के बाकी लोग भी आ जाएं एंड देन आई विल स्टार्ट इंशाल्लाह. Okay, Dr. Nahal is saying, can I briefly discuss about yesterday? आप कल के सेशन में नहीं थी? You weren't in yesterday's session? Because it was a very big webinar, almost about 2 hours, so it'll be very difficult for me to sum up 2 hours of content very briefly. Well, I hope you got the video. वीडियो आपको मिली, वो तो मैंने सारे ग्रुप्स में अपलोड की हुई थी. इट्स अ 5-part वीडियो, तो ठीक है. प्लीज डू गो थ्रू द वीडियो. स्टिल इफ यू हैव एनी क्वेश्चंस तो you can ask here or in the WhatsApp groups, inshallah. So briefly, what I can say till we have a minute or two. So briefly, I can tell you that we discussed 3 types of techniques that we use for taking periapical X-rays. The gold standard technique is the parallel technique. The technique most commonly done here in Pakistan is the bisecting angle technique. And there's a third technique which is called parallax technique. And this parallax technique we use to determine the position of unerupted teeth. So we basically talked about how those X-rays are taken, what is the angulation of the X-ray tube head for those various X-rays, what armamentarium do you need for those X-rays, and in the end we compared what are the advantages and disadvantages of those techniques, and in the end we briefly discussed how to assess image quality for such X-rays, what is the criteria, and then in the end we had one slide about the FJDP which is the Faculty of General Dental Practice in the UK. They have a book published on their website, which is called Selection Criteria for Dental Radiography. It's freely available online. It's not a PDF, but it's freely available online in the form of web pages. So if you download those, you can make a book out of that for yourself. So we briefly talked about what is the rating scale for X-rays, what does rating 1 mean, 2 mean, 3 mean. So we briefly talked about that. So anyhow, I hope you do go through the video, and if there is anything you don't understand, please feel free to ask. Okay, we have 25 participants and it's about 3:06. So I guess we should start then, inshallah. All right, so again, I'm muting all of you, but you have the option to unmute yourselves, and then I hope you do participate. All right. Okay, so Bismillah ar-Rahman ar-Rahim. Assalamu alaikum everyone, and welcome to the second session on periapical X-rays. And today's session, although it's quite long, but it will be almost wholly interactive, because I'm going to try that to get your input on everything. Okay, we have Dr. Ava Adams over here. Can you please check your mic? Because it's audible for everybody else. Dr. Sana, you raised your hand. I think we are audible to everyone. So let me just sort this out. I hope Dr. Eva can then hear us. All right, Acha. Today the contents of the presentation will be that first of all, and this is a common question that I hear is asked in your ORE and MFDS exams, which is how will you differentiate between a lower and upper X-ray? Okay, we still have no audio. Okay. So we're going to discuss how do you differentiate between an X-ray of the upper arch and an X-ray of the lower arch. Then we're going to discuss how do you interpret periapical tissues and their various pathologies. We're also going to discuss how to assess periodontal health, how to do an implant assessment, what are the developmental abnormalities that you may see, some radiolucent and radiopaque lesions of the jaws, dental trauma, and lastly, but most importantly, errors. How do you see errors on an X-ray? So, thank you, Dr. Aisha. Acha. So now I'll request all participants to put your answers in the chat box for now. That if you have an X-ray, so what you have like 5 components that you have to go through in order to interpret an X-ray. So the first component is your general overview. So in the general overview, what do you think you should look for while going through an X-ray? So please drop your answers in the chat box, and let's see how much can you share, how much do you know? Dr. Sana, you're raising your hand. You can put your answer in the chat box. Once I start with the slides, then I'll put on the unmute option on for you. Okay, Dr. Ufak is saying we'll see the quality of the X-ray. Good. And Dr. Leila is saying clarity, which X-ray has been prescribed. Okay. Whether it is of the maxilla or the mandible, fine. Anything else? So it should be side X-ray. Okay. Is it the right or left one? Good. Anterior or posterior? Is it of the desired tooth or not? All right. Anything else? Okay, I think that's about it. Chale, I'll share my answers after that, but let's go for the second thing that you have to look for. Okay, when you're assessing the crown of a tooth, and I'm not talking about the prosthetic crown, I'm talking about the dental crown. So when you're analyzing the crown, what do you think you should be looking for? क्राउन में ऐसी क्या चीजें जो हैं उसको आपने असेस करना होगा? Integrity of the crown, okay. Any fractures? Excellent. Cusp? Any caries? All right. Enamel and dentine pulp, okay. Anything else? Cracked tooth, the contacts, okay, fine, excellent. Any restorations? Excellent, Dr. Marine. Okay, what about the root? What will you look for in the root portion of the tooth? Morphology, excellent. Any root fractures? Lamina dura, completion of the apex, pulp horns, divergence, PDL space, apex, cementum, caries, fracture, apex lesions, excellent. A lot of points regarding the root, bulbosity, periapical pathology, fantastic. Okay, so I think you even covered some of the apical tissues as well in this. Okay, what about periodontal tissues? One point was already answered regarding the lamina dura. Any bone loss? Excellent. Any resorption? Accessory canals? Okay, that will come into the root. The PDL status? Excellent. Anything else? I'll now share what the things that you have covered and the things that you missed out on. Okay, in the general overview, we first look, in addition to everything else that you shared, we look at whether what is the chronological or the developmental age of the patient. All right, like based on the erupting status of teeth, we can have a rough idea about the chronological age of the patient or the developmental age of the patient. So you can have an idea that you're looking at an X-ray of a child or an adult. Okay. So first you try to guess, in addition to everything else, that you have the right X-ray, it is of the right side, of the left side, and everything. You also have to look for whether you're looking at an X-ray of a child or an adult. You also need to look for any superimposed anatomical shadows, which may affect the diagnostic quality of the X-ray, and any developing teeth. Okay. Crown may, like all of you said, mashallah, that you look for the presence of caries, and you will also look at the state of existing restorations. So you covered both of these points. Coming to the root may you'll obviously look at the length. What are the number of the roots? What is the morphology? What is the size and the shape of canals? And you will also look for the presence of any pulp stones, any root fillings, internal, external resorption, or any fractures. So, mashallah, you almost covered all of these points. Now, coming to the apical tissues, you'll look at the integrity or the thickness of the PDL space, the lamina dura, any radiolucent or radiopaque areas. What is the pattern of the trabecular bone? Okay, and coming to the periodontal tissues, you look at again the width of the PDL space, level and quality of the crestal bone, any horizontal or vertical bone loss, and is there any furcation involvement? Okay, so mashallah, most of you you got almost all of the points that you have to look for when analyzing an X-ray. So if you follow this systematic approach, so hopefully, inshallah, you will not miss out on the findings that are present on an X-ray. Okay. Okay. Yesterday, कल हमने एक और बात भी की थी, which was about over and under exposure. Now, does anybody remember when I said that when will we overexpose or when do we optimally expose and when do we underexpose? कल मैंने दो structures के नाम बताए थे आपको. एक structure जिसके लिए for excellent Dr. Lela, for underexposure we do for assessing the alveolar bone, and optimum exposure or overexposure for the teeth. So here is a picture over here. 4 pictures you can see, starting from the left one, jahan bhi mera mouse hai, you can see that this picture is extensively black. All right. So a picture that is extensively black, it means it has been overexposed, because in this you cannot even see the teeth properly. Okay, you can just see faint outlines of teeth and some portion of the root canal, but other than that, all the rest of the area is black. Okay, so the second X-ray that you see now, this is relatively, you can say, somewhat optimally exposed, but there are 2 problems in this X-ray. You will think that there is a huge periapical cyst on this lateral incisor over here. All right. So this is when you get, when there is somewhat optimum exposure or even a bit more than the optimum exposure. And you'll also think that this tooth has cervical caries, so that's why there's a huge periapical cyst over here. All right. Now, if you look at this third picture over here, now this is a picture where this is underexposed. Okay? And how can you tell this is underexposed? In this, you can see that the bone is very shiny, very bright, and you can see that the teeth are looking absolutely fine. You can, in a way, you can say that even the pulp canal seems to be calcified somewhat, because it's not very radiolucent. You can see it maybe in a bit in this portion over here, but in the central portion you can't see it, and the same case over here. So underexposure we do to assess bone height, and if you compare just this portion over here, if you compare this interdental bone area between the lateral incisor and the canine, you'll see that it is approximately at the cemento-enamel junction over here. But in this X-ray, which is somewhat optimally exposed, now in this case the alveolar crest appears to have migrated apically. So you will think that there's maybe a pocket over there, there's some periodontal disease over here. So an optimally exposed X-ray is not good for assessing the periodontal health of a patient. So if you want to do an X-ray to determine bone heights while assessing for periodontal health, you will have to underexpose the X-ray. So how do you underexpose the X-ray? If you remember my first lecture, I told you that dental X-rays operate at a voltage between 60 to 90 kilowatts. So at that voltage, you'll either have to go at around about 60 or below 60 kilowatts. So when you decrease the voltage, that will automatically produce X-rays that will underexpose. And if you go towards obviously 90 or more than 90 kilovolts, then you will produce overexposed X-rays. All right. So I hope this is clear. The last image which you can see, this is extremely underexposed. All right. Underexposure basically results in the production of very weak X-rays which cannot pass through bone or enamel. So, and overexposed, when you increase the voltage, it results in the production of X-rays that have a lot of energy, mean they will go through the teeth with such a velocity, with such force that it will appear that there are no teeth over here, which you can see in this case. All right. So underexposure means underpowered X-rays or X-rays which don't have that much intensity or power, so that they can produce diagnostic quality X-ray. So in this case, all you can see are maybe some interproximal spaces here and the outline of the teeth, but this whole area, you cannot see anything over here. So this is an extremely underexposed X-ray. All right. Okay. So this was one thing that I told you I will cover today. Okay. Another thing that I told you in the start, that which is a common station at your ORE level and MJDF or MFDS level, is differentiating between upper and lower X-rays. So can anybody tell me what are the differentiating points for the upper X-ray? We only have about 6 minutes before this meeting ends. So if anybody can quickly share them, that'll be fantastic. You can start from the anterior. That anterior mein aap kaise bataoge? And then you can slowly go towards the premolars and the molars. That how will you tell that this anterior X-ray belongs to a maxillary molar or a maxillary central incisor? Okay, we have one from Dr. Leila. In upper anterior, you will see the incisive canal. Excellent. That you won't see on the lower X-ray. Maxillary sinus lining for the posterior. Excellent. Dr. Hina, can you elaborate the morphology a bit? You're right, but just explain it a bit. Again, sinus for posterior. You will see the palate in the upper. All right. Number of roots. Lower memmental foramen bhi hoga, definitely. Okay. Lower lingual foramen for the lower anterior teeth. Excellent, Dr. Sarish. Anything else? ID canal, excellent. Bone density in upper and lower jaw. Yes, in the upper jaw, your bone density is relatively less, so it will appear more radiolucent, and lower jaw is more dense bones, so it will appear more radiopaque. Mandibular canal, again, ID canal, repeat ho gaya, but again, good one, Dr. Leila. Anything else? Dr. Hafsa has raised her hand. Ji, Dr. Hafsa? Number of roots of molar, excellent. That is a very good differentiating point as well. Piriform aperture in the upper or the nasal cavity, जो है वो आपको upper anterior X-ray में नजर आएगी, but obviously you won't see that in the lower X-ray. So excellent. I think you've covered most of the points. So let me just go through them. The first point which many of you missed on was that the central incisors of the upper arch, they are wider than your lateral incisors. ठीक है ना? Central incisors बड़े होते हैं, lateral incisors are relatively narrower than your central incisors. But ठीक है? फिर incisive canal और incisive foramen की बात आप लोगों ने की, which you mentioned, which was correct. Secondly, the shadow of the nasal cavity or the piriform aperture, which was just recently shared. So that you will see in the upper X-ray, but you won't see it in the lower one. Then is the Y line of Ennis that you will see in an upper X-ray in the premolar or anterior region, but you won't see it in the lower one. You will also see the maxillary sinus or the shadow of the zygomatic buttress in the upper arch, but you won't see it in the lower arch. The third one is the third root morphology की जो आप लोगों ने बात की, that in the upper row, posterior teeth में you will see the palatal root of the maxillary molars, but you won't see such a thing. And in the upper arch, you will also see the pterygoid process or the maxillary tuberosity, which is obviously a structure which is absent in the lower arch. The Y line, जो है, Dr. Nahal, that is formed by the maxillary sinus and the nasal floor. I think maybe you missed the first lecture, the first webinar I gave. Are you present in any of the WhatsApp groups in which I share updates about this? If you're present in them, so I've uploaded the lecture in that. Yes, so I think you would have had access to the lecture in that. The second lecture, which was on dental radiographic anatomy, I've uploaded the presentation as well as the video, so you can go through that about and see what the Y line of NS is. Okay. I don't have a picture of it here right now because although I wanted to add pictures of all these things, but the problem is it's already a huge presentation and I didn't want to make it any more bigger. Obviously, आप लोगों के attention span कभी वो करना था, ख्याल रखना था. Anyhow, so you can go through that. फिर भी कोई मसला हो, please feel free to ask. Acha. In the lower X-rays, the central and lateral incisors are roughly the same width mesiodistally. Okay. So that is one point. Plus, you have the presence of the lingual foramen, which is situated way below the apices of the central incisors. If you've taken an X-ray of the anterior region, you may be able to see the inferior border of the mandible and the genial tubercle. Where in the premolar area, you will be able to see the mental foramen. You will be able to see the ID canal. You will, in the mandibular posterior area, you'll also be able to see the internal oblique ridge, and below the internal oblique ridge, you will have the mandibular fossa. Okay? So this is how you differentiate between that. Lower centrals are smaller than lateral. I wouldn't say, well, if you compare the amount of discrepancy between them as compared to the upper arch, so in the upper arch, it is very clear because the laterals are very small. Laterals are very small compared to the maxillary central incisors, but in the lower arch, they are roughly the same. I wouldn't say they are exactly the same. Maybe the laterals are a bit bigger or the centrals are a bit bigger. But the difference is clear enough if you are looking at, if you're comparing the two X-rays side by side.